Dear colleagues, my name is Adel Allam. I'm the professor of cardiology at Al-Azhar University, and I'm also honored to be the president of the Egyptian League of Cardiac Imaging, one of the leagues of the Egyptian Society of Cardiology. I need to thank all the members of the board of directors of the Egyptian Society of Cardiology for this excellent educational effort. Dr. Khalid Shukri, Dr. Islam Shawqi, and all the members of the board, and thank you very much for inviting me to be part of this effort. I'm going to give this presentation on behalf of the members of the board of the League of Cardiac Imaging, Professor Dr. Ali Abdel Fattah, Professor Dr. Ahmed Abdel Ati, Dr. Sameh Al-Affas, and Dr. Ashraf Asfour. We are trying here to show how people working in the field of cardiac imaging help in solving some of the challenges that face us in Egypt as cardiologists, particularly in the field of coronary artery disease. So when a healthy person in the prime of his life die or become disabled without a warning, of course this is a catastrophe. And the consequences for the person, the family, the friends, and the occupation is so severe. Fortunately, most of the studies shows that individual under the age of 40, the incidence of a myocardial infarction or symptomatic CED is quite low. In the Western world, it's around 3% of all cases of CED. I'm going to show a case presentation, some case presentations that would show us how the problem of having patients having very advanced CED in young age is a big problem facing us here in Egypt. So MA is a 30 years old male. He comes with a history of previous MI in this very young age. He was complaining of shortness of breath. The only conventional risk factor that he has was dyslipidemia. Optimal medical therapy, some resting ECG changes, perform moderately on a Bruce protocol, has severe SOB but no chest pain, and significant ST and T wave shifts. And this is his perfusion scan. And let me orient you a little bit. So we usually have the short axis slides. Those are the short axis slides, and the stress is usually in the above row followed by the rest. This is the vertical long axis, and this is the horizontal long axis. In the short axis, we're going from apex to base. This is the anterior wall, this is the septum, this is the inferior wall. For the vertical long axis, this is the anterior wall, this is the apex, and this is the inferior wall. And let's go back. And for the horizontal long axis, this is the septum, apex, and the lateral wall. And for you to understand more, if this color is present, then the uptake, the flow is 100%, and if you have the black, then the uptake is 0. And you can see clearly from here that this patient have very huge multiple perfusion defects. One that is mainly fixed in his anterior wall, apex, anteroapical, anteroseptal, and even the apical part of the lateral view. And the other one in the middle of the lateral wall that is totally reversible, in the infralateral that is totally reversible, in the inferior segment that is totally reversible. And we'll show in other color scales, so this is what we call the GE color scale, and this is the gray scale, or the black and white. And here we are looking at the polar map, which put all those cuts together in one map, and you can realize that you have a very large perfusion defect in the anterior wall that is mainly fixed, mainly a scar, and another perfusion defect in the mid-lateral wall and the inferior wall that is totally reversible, and here you see the subtraction imaging showing the amount of ischemia. So how come that a patient that is 30 years old get all this severe coronary artery disease and ischemic heart disease in this young age. And we can see from here that the ejection fraction is around 30. And if we gauge the study, we can clearly see that in the post-stress and the rest studies, there is a large regional wall motion abnormality involving the whole area of the LED, and that the volumes is extremely dilated. So what did the anatomy say? Very critical multi-vessel disease with a thrombus-containing lesion in the LED. And here is his angio. Please note that this patient is 30 years old. So, we did a study with some international colleagues that involved a registry for acute coronary syndrome in Egypt. Actually, this study included many hospitals in Cairo, around 6 hospitals, Al-Azhar University, Bab al-Shariya and Hussein Hospital, Dr. Ahmed Abdel Ati from Mustashfa Salam, professor of cardiology at Alexandria University, the critical care department in Cairo University, Dr. Ali Abdel Fattah, and many of our colleagues from Wizard al-Sahha, the hospital of Madinat Nasr Ta'min Sahi, and of course the National Heart Institute. This was a registry for acute coronary syndrome, and we had very eminent international figures that were part of this registry. Dr. Harlem Kromeholz from Yale University, Dr. Elizabeth Bradley, and people from the University of Northwestern. So what did this registry show us? It showed us that the mean age of acute coronary syndrome in Egypt was typically around 7 years younger than the Western world. And it also helped us to see how those younger patients may have a different presenting clinical characteristics and difference in the management and outcomes. And this has been published internationally. The total number that were included in the registry were around 4,700 patients. And when we looked at a subgroup, which are the patients below 45 years or younger, they were 14% of the total population. 7% in females and 15.9% in males. So what was the characteristics of younger patients? And as you see in red, younger patients, they mainly present as STEMIs. When you look at the conventional risk factors, namely hypertension, dyslipidemia, and diabetes, you would find that younger patients tend to have lesser conventional risk factors. So lesser hypertension, lesser dyslipidemia, and lesser diabetes. But in comparison, and in addition to being males, they are more prone to be smokers, and they're more prone to have problems with drug abuse and the use of narcotics. And in this registry, the variable that we asked for was cocaine abuse. We'll shift to cardiac imaging, and we are going to go to a registry of myocardial perfusion imaging, SPECT studies, done in an outpatient radiology lab in Cairo. Around 11,000 patients, and all the data I'm showing today are data from Egypt. And this is very important for the country here, that we use our data so that we can manage our patients properly. So around 11,000 patients who underwent myocardial perfusion imaging in one of our outpatient radiology labs. And as you see, they are predominantly males, and the age is the mean age is 54 years with very high conventional risk factors, hypertension, dyslipidemia, and diabetes. And the majority of them are known to have CED, whether they had a previous MI or previous revascularization. I'm going to put beside this table a table from one of the Western world studies. And you can realize immediately that we have a difference of around 10 years in the age, and that the male population is more presented in the Egyptian data than in the Western data, and that we have more conventional risk factors. And please notice that the size of the defects here are around 4%, 5%, because you will realize in the next studies that I'm going to show that we have much more severe ischemia. The positivity rate in the 11,000 patients was 40%. But when we look at the summed stress score, which is the size of the perfusion defect, in the 4,228 patients who were positive, the mean was 17%, with nearly half of that as ischemia, and with ejection fractions that is in the normal limits. This figure is very important, because more important than that we have 40% positives is the fact that 70% of those positive studies have large defects. 70% have defects 10% or more, 20% or more, or 30% or more. That means that in our Egyptian population, patients coming to a nuclear cardiology lab usually have very large perfusion defects. So in this study, patients who were younger were 5%, 3.2% males, and 5.5% females. When we look at the clinical characteristics, we will find again the same as what we saw in the registry of acute coronary syndrome. Lesser risk factors in the young, conventional diabetes and hypertension, but more smoking, and they present more with a myocardial infarction. Rather, so the younger presents more with a myocardial infarction, and they are smokers more. They have more history of premature CED, but lesser history of diabetes and hypertension. Again, we will find that the size of the perfusion defects in the young is as big as the perfusion defects in the old population. So I'm going to show two more patients very quickly. This is a 35 years old male. And if we look at his perfusion scan, a large reversible perfusion defect in the anterior wall and another fixed one in the small fixed one in the infralateral segment. Different colors. This is the myomap again, showing this large perfusion defect in the anterior wall that is totally reversible, and a small perfusion defect in the inferior infralateral that looks to be fixed. And here you can see that there was a regional wall motion abnormality in his anterior wall that disappeared totally in the resting study. So what did his coronary angio show? A critical RCA thrombus-containing lesion, which was related to the inferior STEMI, and a tight mid-LED. And let me show you the angio. And again, a patient in the 30s having significant coronary artery disease as what we are seeing. Okay, a third patient, again a male, again a 31-year-old, and again history of previous infarction and primary PCI. And this time a perfusion defect in his anterior wall that is mainly fixed. And when we go to the polar maps, again you can see this perfusion defect there, and it is mainly fixed here. Let's go to the function, a wall motion abnormality in the territory of the LED, and multiple critical lesions in his LED and diagonal. And I want you to look at the severity of this atherosclerotic lesions in a patient that is 30 years. So younger patients are more likely to present with STEMI in Egypt in context of frequent tobacco use and maybe cocaine abuse or narcotic abuse. Prevention strategies for individuals 40 years and younger in Egypt should target tobacco and cessation of narcotics. I'm showing you here a study coming from one of the centers in the east of the US that is talking about how coronary artery disease and ischemic heart disease decreased in the US between the period of 1996 and December 2012. So when they looked at the MPI in around 100,000 patients, they showed that the positivity rate dropped from 47% to 39%, and that the ischemia too dropped. when they looked at coronary angios from 150,000 patients, they found that single artery, one vessel disease dropped from 29% to 22%, and multi-vessel disease dropped from 50% to 35%. So in the Western world, coronary artery disease and ischemia are decreasing. We did a study with Randy Thompson from Kansas City, and here we are showing the data from Egypt from the year 2005 till the year of 2014, 10,000 patients, and a bigger number even from Kansas City. And we are showing here that as we progressed from the year 2000 to the year 2014, there was a drop in the frequency of positivity on MPI. This was true for the United States, represented here by Kansas City, and for Egypt too. But remember that the positivity in Egypt is 40% of the patient, but still 70% of those studies are all very large perfusion defects. I'm going to show you this last patient who is 59 years old and who exercised very poorly for 3 minutes, had significant ST segment shifts. And please realize with me how severe is this ischemia. Ischemia in all territories of the heart, the anterior wall, the lateral wall, and the inferior wall. And the question I'm going to ask you, should we revascularize this patient? We revascularize patients to have a better outcome and a better quality of life. Some previous studies has shown that as we increase the amount of ischemia, we need to revascularize because patient would do better regarding the outcome. But then the COURAGE trial, the BARI 2 trial, shows that there is no difference between optimal medical therapy and interventions. Recently, the ischemia trial 2 showed that there was no benefit regarding the outcomes. But look here in the data of the ischemia trial. If you have very mild or no ischemia, as in 11% of their patients, there is no benefit. But if you have severe ischemia, as in 50% of their patients, there is some benefit in favor of intervention. And there is also benefit in the improvement of quality of life and lesser frequency. So what did they conclude? Patients with stable CED and moderate to severe ischemia who have had significant improvement in angina control and the quality of life in the invasive strategy if they had angina. If they didn't, they didn't show much improvement. So the conclusion was in patients with angina, shared decision making should occur to align the treatment with patient goals and preferences. So what does this mean? Does this answer the question of should we refer patients for revascularization? Particularly in a country like Egypt where we have very severe ischemia at a very young age, patient like this patient, can we leave him without revascularization? We are going to answer this question with a big study that we are going to publish very soon in the one of the big international journals. And the answer to the question is going to come from data from Egypt, from the work with our hands regarding the intervention and regarding the medical management. And I would like to leave you at this slide and promise you that you will soon have an answer for this question. And please stay safe and keep your country, Egypt, safe. In the end, I would like to share this link that would lead to a survey done by the International Atomic Agency in Vienna. Please, if you are working in the field of cardiac imaging, you can participate in this survey, or you can be in contact with me. And thank you again. وكل سنة وانتم طيبين.